title of this lecture is Obesity, Ethnicity and COVID-19. And I'm Cameron Razieh, and I'm an epidemiologist at the University of Leicester. And more specifically, I work within the Diabetes Research Unit within the Leicester Diabetes Centre at the Leicester General Hospital. And essentially, what me and the team that I work with and my supervisors, we do on a day-to-day. At the moment, we work with larger data sets and we look to investigate associations between certain health factors such as obesity and ethnicity, and look at outcomes. So in this case, it's COVID-19. So an overview of the content I'll be showing you today. So we'll just go through some quick definitions because I'm aware that everyone may have a different background, so not everyone might be understand everything straight from the word go. And we'll touch on the background into the topic. So the early COVID-19 risk factors, obviously focusing on ethnicity and obesity, and then also what was known about obesity, ethnicity, and disease risk before the pandemic. We'll then look at current data from the pandemic, investigating obesity, ethnicity, and COVID-19. So this will predominantly be work that the group that I work for, that we have done, but also some other relevant work which has been published during the pandemic. We'll then go on to look at potential mechanisms of this increased risk in certain minority ethnic groups with obesity and COVID-19. And then we'll finish with some discussions and final thoughts. So here we go. So some quick definitions. So the first one that I'll touch on a lot is ethnicity. So obviously, I'm sure everyone knows what ethnicity is, but it's a broad term, and it really relates to someone's social factors and cultural factors and things like language, diet, religion, your social norms, and how people identify, and usually people identify in a group. Importantly, ethnicity focuses on biological traits as well. So that would include someone's skin tone, for example, whether that be dark or light skin tone. And importantly, this term differs to the term race, which is based purely on biological traits. And that was really predominantly used within the United States, whereas I think in the UK, ethnicity is a term which is probably used slightly more often. Obesity is another word that we'll be focusing on, and essentially the definition of that, as I'm sure a lot of you are aware, but just in case if you're not, abnormal or excessive fat accumulation that presents a risk to health. Generally, this is measured now through body mass index, which is known as BMI, and this is a formula that uses your height and weight to work out if your body weight is healthy or not. Generally speaking, a BMI of over 30 is classified as obese, and a BMI of over 25 is classified as overweight. So there are some somewhat statistical terms purely for the graphs that I'll be showing you, which is an odds ratio, which essentially all an odds ratio is the risk of having an outcome. So for example, COVID-19 mortality in one group. So for example, South Asian groups compared to another group, so white British groups. A hazard ratio is very similar, apart from a hazard ratio is measuring that risk over a specific time period. So when we look at the pandemic, when it was beginning and we looked at what was happening, obviously it was new to everyone. So I don't think I need to introduce what COVID-19 is. I'm sure we're all very aware, having been living with it for the past year and however many months, and it's all changed our lives hugely. But when the preliminary data was coming in last March and we were getting to grips with this initial virus, what we found was certain groups within the population were at higher risk of more severe disease, complications, and unfortunately dying from COVID-19. So these people were older individuals, people living with obesity, people from ethnic minority backgrounds, people who lived in more deprived areas, and also people who have underlying health conditions, predominantly around cardiometabolic conditions, so things like diabetes and heart disease. So some of the very early data, some of the first data actually that was coming out, because at this point in the pandemic, it was new to everyone. No one knew what to expect or what was going on. And some of the first data is the ICNARC data, which stands for the Intensive Care National Audit and Research Centre. And essentially that just measures and collects data on people admitted to critical care within hospitals. And what we found was, I'll just quickly make this a pointer. What we found was here, when we look at BMI and people being admitted, for example, it was about 3/4 of patients admitted to ICU in the first wave of the pandemic, so up to the 31st of August, but especially early on, were people who were classified as overweight or obese, which is greater than what you'd expect in the general population. Similarly, when we looked at the ethnic breakdown of these patients being admitted, what we found was 34% of patients admitted to critical care were from an ethnic minority background, which again, compared to the general population, is more than you'd expect. So these were some of the very initial triggers that we found, or very early signals that obesity and ethnicity may be important factors for the for increasing your risk of COVID-19. So there was another paper. This was done in 17 million people. So this was published. Oh, sorry, it wasn't published. It was made available in May, early May. So this again was quite early in the pandemic. And again, what they found was in 17 million people using electronic health records. So that's through health records such as your GP records. What we found was, so they did this analysis where, if you can see this red jagged or square, and I've just transferred that out here so it's bigger so you can see that. And this line, so this jagged red line means that's a reference group. So for example, if we look at obesity, what we find is that people who are class 1 obese, class 2 obese, or class 3 obese are all at increased risk compared to the reference group of someone who isn't obese of dying from COVID-19. And this was particularly pronounced in people with greater obesity, so class 2 and class 3. Similarly, when we look at ethnicity, so compared to the reference group of white British individuals, what we see is all ethnic minority groups are at increased risk of dying from COVID-19 compared to the white British group. And we can tell that by these dots here being further away to the right-hand side of this line. And these are the corresponding values if anyone was interested in them. So again, just to sort of emphasize the point of how much news coverage there was around this. So this is just a snapshot of some of the articles that were getting published at the time in BBC. Obviously, there are other news outlets available, but there was a lot of news about this and about the potential increased risk. But still, at this point in time, there wasn't a great understanding of why this was. And similarly, when we look at obesity again, there was quite a lot of news articles around obesity increasing the risk of COVID-19. But again, at this point in time, there hadn't been much investigation into combining these and trying to understand, do these factors, so ethnicity and obesity, do they interact? And then lastly, just to sort of hit home about the ONS data and the risk of ethnicity. So as more data was collected, ONS is probably the best provider of statistics within the UK. They provide statistics on a whole host of different factors and areas such as the economy, but also health. And they did an analysis, and what they showed was that Black African and Black Caribbean individuals, if we look at this line here and this line here, they're up to 3.5 times more likely to die than white British individuals who were used as the reference group. However, most ethnic minority groups were at increased risk compared to the white British group. When we adjust for different factors, so things like your education, your income, your underlying health status, what we found was this reduced the risk in a lot of these ethnic minority groups, but there was still, increased risk compared to white British people. And, again, this was pronounced in the Black African group at this time. So this bit here, what I'm showing you, this only relates to wave 1. There has been data since that wave 2 affected the ethnic groups slightly differently, very similar, but very slightly different. So then to relate these two independent factors, obesity and ethnicity, we need to sort of go back in time and then understand what was known about the relationship between ethnicity and obesity pre-pandemic. So what we knew before was that for cardiometabolic risk, for things like heart disease, things like type 2 diabetes, in some minority ethnic groups is actually higher than white individuals at lower levels of BMI. So I'll go on to show you some graphs in a minute, but when we look at the actual overweight and obesity rates within the general population in the UK, in the Active Lives survey, which is a survey done to collect data on lifestyle factors, including somebody's obesity status, we found that 62.8, so essentially 63% of people classified as overweight or obese. So this graph sort of just emphasizes that. So as we can see, as we all know, over time, people are, generally speaking, becoming more. There's more people who are overweight and obese, and here we are. So about 60. It was 63% in 2019. When we look at individual ethnic groups and how their levels of obesity differ within the UK, what we find is that most minority ethnic groups are actually have lower levels of obesity compared to white British group. So the white British group is here at 63.7%, whereas when we look at an Asian group, they have a prevalence of obesity of about 60%. However, when we look at a black individual, their rate of obesity is 67.5, which is obviously higher. And that mirrors other research which has been done, for example, in UK Biobank, some work that we've done here, that Black African or Caribbean individuals actually have slightly higher BMI and higher levels of obesity within the population compared to white British people. Whereas a South Asian individual, so someone who is Indian or Pakistani or Bangladeshi, they have lower rates of obesity. But this doesn't necessarily translate into lower disease risk. It's just levels of obesity and BMI. So to explain that a bit more, there was a study done in Canada with about 60,000 people. And what they showed was that if we look at, so the outcome that this group were looking at was incidence of diabetes. And this is measured in incidence per diabetes per 1,000 person years. And then what we have along this axis is body mass index. So what they showed was for a white individual with a BMI of 30, what you'd expect the incidence of diabetes to be per 1,000 years would be about 11. Whereas if we go to a BMI of 30 for example, a South Asian individual, so for the same BMI as a white individual, their incidence of diabetes per 1,000 years would be about 36. So obviously that's far higher. And actually, for a South Asian individuals to have the same incidence of diabetes per 1,000 years as a white individual, they would have to have a BMI of, if we go across this jagged dot line here, of 24. So that's quite stark, actually. It's an important point. And then this work has been replicated since. So this is a very recent paper, actually. This is in 1.5 million people in the UK. And again, very similar sort of figure as the previous one. What we have here is type 2 diabetes incidence per 1,000 years. Per 1,000 person years, I should say. And then again, along this axis here, we have BMI. So again, lower BMI indicating healthy or underweight. going through to the middle section through to here, which would be classifying as obese from 30 or above. And again, what they showed was a white individual with a BMI of 30 has about a type 2 diabetes incidence per 1,000 person years of about 10. Whereas for a South Asian person to have a diabetes incidence of 10 per 1,000 person years, they would need to have a BMI of, again, 24, which again is a stark difference. And again, it's consistent between the two studies, which is reassuring. So when we combine all of this, so what I've just shown you, we had a hypothesis when the pandemic began, and it was based on the early risk factors, which included ethnicity and obesity, but also the work that I've just shown you now, that actually certain minority ethnic groups have increased risk of certain diseases at lower BMIs. So we thought that obesity may act to explain some of the increased risk of COVID-19 across minority ethnic groups. So we're going to focus now on some of the early data that we produced in the pandemic. And this is from the time from about April to June. So along the top here, this is cases, and this is from the government dashboard. And then along the bottom here, we have deaths or mortality, however you want to call it. And as we can see here, there wasn't much testing going on because we were focusing on healthcare providers, healthcare workers and people in hospital. However, what we can see was this was definitely the first peak, and unfortunately, quite a lot of deaths. And, what was going on at the time, just a bit of a sideshow here. At the time, this is what I remember when I was making this last night. A lot of people were making banana bread. A lot of people were banging pots and pans at 8 p.m. for the NHS. Couldn't seem to get any toilet paper. And there were some protests about Black Lives Matter, and, everyone began to wear masks. So some of the early data that we did. So again, this wasn't focusing on ethnicity because first we had to see actually with data whether obesity and markers of obesity increase the risk of testing positive for COVID-19. So what we showed in about 4,000 people was that the risk of testing positive for COVID-19, so this is only to actually test positive, not to have a complication or potentially die. To actually test positive, was the risk is higher if you are at about, if you are essentially overweight or obese, the risk is higher compared to the reference, which was someone with a BMI of 25. And similarly, this was the same pattern we showed with waist circumference. So if you had a waist circumference higher than 80, your risk was higher to test positive compared to a person whose waist circumference was 80 centimeters. So this is where we then began to apply our knowledge into ethnicity and obesity. And then we looked at an interaction. So an interaction is essentially to test whether the BMI, so whether BMI affects both white British people and ethnic minority groups the same in terms of their risk for COVID-19. And again, what we have here, so this is the odds ratio that I mentioned earlier, which again is the risk relative to another group. So what we found was that at lower BMI, there was no difference in testing positive between white British people and ethnic minority individuals. Whereas if we moved along the BMI continuum to higher levels of BMI, what we found was that ethnic minority individuals were actually increased risk of testing positive compared to white British people. And this graph just shows the same essentially, apart from instead of having both ethnic groups on here, this blue line is the white British group, and this is the ethnic minority group sort of relative to them. And as we can see, at higher BMIs, greater than about 28, the risk increases to test positive for COVID-19. So other relevant work that was going on at the time. So again, this was very early doors and there was a lot going on. It was very new to everyone. So the government produced the Public Health England produced a report into excess weight and COVID-19 risk, which luckily we were referenced in, which was great. There was a lot of initial work and editorials and other work like that into the risk of minority ethnic groups and why seemingly ethnic minorities within the UK were at increased risk of, poorer outcomes of COVID-19. There was some further work here, which again, very similar, showed that non-white individuals were at increased risk of dying from COVID-19 compared to this blue line, which is the white group. So that was some of the work really quite early in the pandemic that we produced here at the Diabetes Centre. And then we moved on to, this point in time between the red dotted lines. And this was from about July to December. So as we can see, the first wave is coming to an end. And as we move into, it was about October time from memory, we began to move into a second wave where infections were increasing, and then obviously that translated into hospital admissions and death. And again, what was going on at that time, from all I could remember last night, was the football restarted, which was great for me personally. You could go to the beach and go on holidays within the UK. I know there was a lot going on about that. I think in August time, the Eat Out to Help Out was going on. And then for some reason, I remember Bake Off was on. And I think that inspired a lot more people to bake at the time. So, as I mentioned, this is some work we've done. And as the pandemic progressed, more data became available and more data sets. So people, scientists and people working within government and other organizations, universities and such, they were understanding more about the disease. We were collecting more data. And this is actually data from the ISARIC data set, which is a data set of hospitalized patients who are admitted to hospital with COVID-19 in England, Scotland, and Wales. So there you go. I'm just trying to move that. And what we found was, what we found was that if we look here, for example, in younger individuals from about, probably about the age of 70 and below, 65 and below, that obesity was actually a really important factor for increased risk of mortality. So these two graphs here are looking at mortality in both men and women. So what we found was, compared to the reference group here, which is this dot just here, of, let's just say, for example, a 50-year-old male who wasn't obese without any chronic disease, a 50-year-old male who was obese without any chronic disease was at increased risk of dying compared to them. However, a non-obese individual with chronic disease, so for example, type 2 diabetes, was at even higher risk compared to the individual without obesity or chronic disease. But importantly, the individual with obesity and chronic disease was at the most risk compared to this individual who didn't have obesity or chronic disease. And this pattern was the same in the age groups of below 50, 50 to 59, and 60 to 69. And this was fairly consistent in men and women. And in women, in fact, there is a bit of a pattern here, but it's not as strong. And essentially what we found that was in younger individuals, obesity is a more important factor for poorer outcomes. So in this case, dying from COVID-19. And we don't know for sure why this might be. There's still a lot of research into this. But obviously, as individuals age is a big predictor of a lot of health conditions anyway. Whereas at a younger age group, added conditions such as obesity may increase the risk of dying from COVID-19. So again, this is where we applied our knowledge into ethnicity and obesity, and we want to investigate how these two factors are related to each other in the same cohort using people admitted to hospital with COVID-19 in Scotland, England, and Wales. And this was on about 65,000 patients admitted. And this was really focusing on the first wave. So from let's say, April up until October is when this data applies to. And what we found was so if we look at, we looked at 3 different outcomes. So being admitted to critical care, having to be on mechanical ventilation, because in certain patients who are admitted to ICU, for example, their lungs, as we know, COVID-19 affects the lungs in some people, they weren't able to breathe by themselves, so they had to be put on a ventilator. So that's what this outcome is. And also mortality, which is dying from COVID-19. And what we can see is essentially the white individual without obesity, so compared to the white individual without obesity, a white person with obesity is at greater risk. However, when we look at a South Asian person with obesity, a black person with obesity, these are at far greater risk compared to the white person with obesity, but also the white person without obesity. And importantly, what we see here is, particularly for mortality, clearly we know that in all ethnic groups, obesity is an important factor in COVID-19 risk, as we can see. A white person with obesity is at higher risk compared to a white person without obesity. But what we see here is the difference between this point and this point is much smaller than this point and this point. So these two here, so a black person with obesity here and a black person without obesity, the risk is much more pronounced in this group, and it's also a bit more pronounced in a South Asian individual. So what this told us here, there was an interaction between ethnicity and obesity when looking at COVID-19 mortality, which again was a novel finding at the time, and it was gone on to lead on to subsequent work. But again, that was another finding to show that, in line with the work I've mentioned previously about type 2 diabetes incidence and how that happens at a lower BMI for South Asian individual, this work, it doesn't reinforce that, but it may support it, and it warrants further investigation that essentially obesity outcomes are poorer in black individuals who are obese compared to white individuals who are obese. Again, this is from the same work that we did, apart from its stratifying the cohort into specific groups. So, for example, if we look at mortality, and what we see here is similar to the previous graph, that black individuals, so black individuals are denoted by the red dots, are at increased risk of dying from COVID-19. And this is, for example, here, if we look here, this point denotes a black individual, a black woman with obesity, and this compared to this line, which would be a black woman without obesity. And as we can see, obesity is a risk factor, and this is particularly pronounced in the black group. However, obesity is an important factor for the white group as well, but these differences are slightly larger in this group here. So other relevant work which was going on at the time. So at this point, I think from July to Christmas time, there was actually lots and lots of work going on into obesity and COVID-19, and there's far too much to show everyone here. And again, there was some work going into ethnicity and COVID-19, not quite as much work investigating these associations and how ethnicity may increase the risk of COVID-19 outcomes, but there was some work into this. However, there wasn't that much work looking at both of them combined, as I've just showed you. And other work that was going on at the time, so there was a governmental report into the disparities into the risk of COVID-19, which focused on ethnicity and obesity independently. We've done some more work here looking at the ethnic risk and whether this is potentially because of deprivation or made worse by deprivation. And there was other work here looking into obesity and ethnicity. So as time progresses, and I've sort of taken you through a chronological order here of the work that we've done and also what was going on at the time. So now we move on to January or the start of this year through to present day. So as we can see here, there were still cases, and cases rose until I think it peaked in early January. And again, this translated into COVID-19 deaths and hospital admissions, unfortunately. And then obviously as time progressed, we brought that level down, and now here we are. Who knows what will happen next? So what was going on at the time here? So pretty recent, so hopefully we all remember, but vaccines became much more prominent, and hopefully they do a great job. We can now, to some countries, we can travel. Shops, restaurants and bars began to open, and obviously the dreaded variants all became, it was a word in our vocabulary which became much more common, and we all speak about variants now. So we've actually done some further work, which unfortunately I can't share the graphs with you because it's not been published yet, but it's just about to be published, so I can talk about them. I just can't show you. So we worked with the Office for National Statistics, which I mentioned earlier. They're probably one of the, the holy grail of statistics, let's say, in terms of the UK and what they do. And they have data on the whole of the UK, so they do the census, which we've recently filled in at the start of the year. So using their data, we analysed the data of 12.6 million people between January and December. There we go. And we investigated the association between obesity with the risk of dying from COVID-19. So very similar to what I've shown you previously in the graphs that we've done. So very similar to, actually I'll show you. And what we found was the association between BMI and COVID-19 mortality was stronger in ethnic minority individuals. And I will quickly, show you as best as I can. So what we found was, if we pretend, it was similar to this graph essentially. And at lower BMIs, the risk of dying from COVID-19 between ethnic groups was very similar. There was no difference essentially. However, where we moved up high levels of BMI, ethnic minority individuals were at far greater risk of dying from COVID-19 compared to white British individuals. And this was for South Asian individuals, for Black African or Caribbean individuals, for individuals who classified as other, or Arab individuals as well. So this difference was really quite stark in quite a large population of 12.6 million people. So I'll bring it back. And then other relevant work going on at the time. So this was a paper, again, it was quite recent. This wasn't looking at ethnicity and obesity. This is just looking at obesity. And again, as you can probably guess from the theme of this slideshow, is that higher levels of BMI were actually associated with increased risk of COVID-19 mortality, but also ICU admissions, so being admitted to critical care in hospital. Interestingly, for COVID-19 mortality, there was a slight U-shaped curve here. So at lower levels of obesity, low levels of BMI, there was an increased risk of dying from COVID-19, and the lowest risk between about 23 to 29. However, they did do some work into ethnicity, but it wasn't a graph, a nice figure I can show you. Essentially, what they showed was, if we look at this, so this line here is essentially no risk. There is no risk, let's say. You're not less at risk, you're not more at risk with this line. And what we look at here, so Black individuals, this dot here, because it's on the right-hand side, what that means is they're at increased risk of dying from COVID-19 compared to the reference. And this was the same for South Asian individuals. And it sort of mirrors the work that I just mentioned to you about how minority ethnic individuals are at increased risk at higher levels of BMI. So we're going to move on to the potential mechanisms of why this increased risk may be here. And it may sort of be found in ethnic minority individuals. So unfortunately, this is quite a lot of text. I couldn't really find figures or graphs or pictures to help explain this. So I'll explain the potential mechanisms of the suggested increased risk in people with higher BMIs and people who are obese first, and then I'll move on to how this may translate to ethnic minority individuals. So some of the work so far that's been done has found that obviously COVID-19 affects the pulmonary function, especially when lying supine, so that's when on your front, and this reduces functional capacity. And that's more prevalent in people with excess weight, so people who potentially are classified as obese. Obviously, plenty of research previously before the pandemic has shown that high levels of BMI and obesity are associated with a host of cardiometabolic diseases, such as type 2 diabetes, such as heart disease, stroke, and other factors like that. So if these people have more underlying diseases, that puts them at greater risk of COVID-19, because what we saw was people with underlying health conditions were more at risk. What we also found was that the virus, so the COVID-19 virus, we'll call it, when that enters the body, it has receptors and it binds with cells within our body. And in individuals who have a higher BMI or are more obese, have more adipose tissue, have more fat tissue, that's actually shown to provide more receptors that the COVID-19 virus can actually bind to and then enter our body. Similarly, so related to that point, really, this point here, with people who have more adipose tissue or fat tissue in the body, that means the infection may potentially be able to spread around the body quicker compared to an individual who had less adipose tissue. And then I know there's been a talk previously, if anyone attends these regularly, that Scott Willis did, looking at differences in types of fat and ectopic fat and visceral fat. But essentially, ectopic fat is fat around the organs, and visceral fat is the fat, within your body, not necessarily directly around the organs, but within your abdomen, let's say. And excess levels of this type of fat has been associated with inflammation, which has then subsequently been associated with poorer outcomes in COVID-19, because COVID-19 essentially, what we think, induces inflammation, hyperinflammation, and if an individual already has high levels of inflammation, then their baseline risk is potentially higher. So then when we try and apply this specifically to ethnic minority groups and why ethnic minority groups at higher BMIs may be even further risk. So as we mentioned, in some minority ethnic groups, so I'll use the example of a South Asian individual. Generally speaking, the prevalence of type 2 diabetes is higher in South Asian populations. So this means they have higher levels of insulin resistance. They also, generally speaking, store their fat a bit differently to a white European individual, and they may store their fat more around the trunk region of their body. And all these things mean that actually it puts not South Asian, it just puts minority ethnic groups, some minority ethnic groups, at increased baseline risk compared to an individual without these conditions. And again, the increased storage of this type of fat, as I've just mentioned, it can potentially lead to more binding sites for the virus to bind. And then once the virus is bound to these sites, it can spread around the body more quickly if there are more of these cells. There's higher levels of inflammation within these groups, again, and that relates to potential levels of adipose, so fat tissue in the body. So essentially all these points here suggest that there's greater potential for chronic inflammation within minority ethnic groups, and this may be conducive to poorer outcomes for COVID-19 if infected with the virus. So this is one figure that I found actually from a systematic review, which is where someone or a group of researchers and scientists, doctors, they collate as much data as they can from all the studies that have been produced, and they collate them and they try and understand, they sort of look at the average of all the results and understand, okay, what are the results when we put them all together? And by putting them all together, you can take, you have more people, and then you can sort of average it out and say with more confidence, this may be what's going on. And what we found was, so with individuals, with minority ethnic groups when infected, so around what I've talked about today, increased visceral fat, increased type 2 diabetes, increased hypertension and dyslipidemia, non-alcoholic fatty liver disease. All these factors are, generally speaking, sometimes they're more prevalent in minority ethnic groups. So this may be why it increases the risk of poor outcomes, and then relates to greater inflammation and a pro-inflammatory state, which, as far as we're aware, we think induces poorer outcomes once infected with COVID-19. So what are all the, implications of this work? Because, that's something that I find important, because you can do all the research in the world, but if it doesn't actually go to any use, and there's no point doing it. So the discussions and implications around this really focus on around risk identification. So, for example, if an individual is admitted to hospital, if we can look at their obesity status or their BMI, their ethnicity, as well with other well-known factors, we can actually sort of identify, okay, what sort of risk is this person at? Similarly, we're still living with the virus. Luckily, the increase in infections hasn't translated into increased hospital admissions to a point where the NHS is struggling, and it hasn't translated into a point where we're really seeing quite a lot of excess death. However, we don't know what will happen in the future. And also globally, in other countries, it's important to know. So it's, again, important for risk identification for these reasons. Similarly, for vaccine programs, obviously within the UK, we're quite far along with our vaccine program. But again, in other countries, especially more developing countries, the actual vaccine rollout is really low. So it's important for information around that, because once older individuals are vaccinated who we know are at a really high risk of COVID-19 outcomes, this may help with deciding who else is in a priority group for vaccination. And more generally, I think, and this was important before the pandemic, but maybe it's reinforced it, was that we need, as a nation, as policymakers, the government, everyone really needs to target obesity more in the whole population, but also certain subsets of the population. So, for example, certain ethnic groups. So, final thoughts on what I have shown you today and the take-home messages. So, at higher levels of BMI, what we found was ethnic minority individuals are at greater risk of testing positive, developing more severe and subsequent complications, and also dying from COVID-19 compared to white British people at the same level of BMI. And I've not really talked about this in the presentation because I didn't think it was necessarily that useful based on, I don't know everyone's background, but this is accounting for lots of different factors. So people's age, deprivation, social factors, and underlying health status. And we've repeated this in different data sets, and we're finding the same findings, which is reassuring, but also, we still need to do more to make sure we can investigate these associations. And then more generally, like I've mentioned, we need to do more about obesity prevention as a nation and globally. And then also more work needs to be done into ethnic inequality because, there's lots of potential factors that may be important in driving this increased ethnic risk. So thank you very much for your time. Hopefully you enjoyed that and I didn't drone on too much. Yeah, my email's there if anyone would ever want to get in touch for any reason. And then also, if anyone's got any interest in, the cardiometabolic health or COVID-19 or taking part in research, please contact the Leicester Diabetes Centre. However, I'm sure Loughborough also have relevant contact details to contact as well. So thank you.
Thanks, Cameron. That was a really great talk. Thank you. Just while we're waiting for people to think of questions, we have actually had one come through the chat, if that's okay, which is there anything specific that people from an ethnic minority background can do to reduce their BMI and therefore reduce their risk of catching COVID?
Thank you. Oh, great question. So in the short of it is no, there's nothing specific that a person from a minority ethnic background can do specifically to lower their BMI and their obesity status compared to a white British person, for example. All the same principles apply in terms of lifestyle factors, for example, physical activity, diet, generally getting enough sleep, trying to live a stress-free life as best as we can. And then I think the important thing is to know that certain minority ethnic groups, for example, because a lot of the work we do is around South Asian individuals, that sometimes these individuals are at baseline higher risk, which isn't fair, but unfortunately that seems to be what the research suggests. So sometimes it's a case of having to be particularly careful if you're from a minority ethnic background.
Lovely, thank you. And I've just actually had a second question ping through, if that's okay. Has there been any research for why individuals with a BMI less than 23 were also at risk of dying from COVID? The question has seen on one of the graphs.
Yeah, I'm just trying to think. So because, I think, I don't know whether this relates to, there's ethnic specific cut points where for South Asian individuals specifically, there's a different cut points. So what we know for a white British person, the cut points for BMI are 25 is anything above 25 to 30 is overweight, anything above 30 is obese. Whereas for a South Asian individual, anything above 23 to 27.5 is overweight, which is obviously lower on the BMI scale compared to the white group, and anything above 27.5 is classed as obese. But I think that doesn't necessarily mean that just because in South Asian individuals is it lower than a BMI of 23, as I've mentioned, because of all the factors that interplay, and there'll be further factors that we've not researched, we've probably not even scratched the surface. All these things into play. So a South Asian individual with a BMI of less than 30, their risk may still be high. It just might not necessarily be as high if it was higher. And obviously, this virus with COVID-19 affects everyone differently. So as we've seen, people who seem outwardly very healthy have unfortunately passed away. So there's no hard and fast rule, but I think on average, the lower BMI South Asian or minority ethnic individual would have, the better risk they'd have, the lower odds they'd have of dying, is what I should say.
Thank you. We've got a few more coming through actually now. So the UK government already have policies around obesity. Do you think these are enough? And if not, what do you think we should be doing more of? Tough question.
Yeah, bit of a political question, I guess. I mean, in reality, probably not. I don't think we are doing enough, because otherwise we wouldn't be where we are. Obviously, the rates of obesity have increased, and generally we know this has knock-on effects for secondary care and GP practice and all that sort of thing. And I think generally within the UK, at least anyway, the way obesity is viewed and the way we prevent it at the moment is very much on the individual, whereas I think, generally speaking, as a nation and as a government and whoever else, we could probably treat it more as it's the environment. We need to help everyone. We need to improve the environment. We don't need to leave it to the individual, because my viewpoint would be we are a product of our environment. So if the environment isn't conducive to maintaining a healthy weight, well, then it's going to be very difficult for a lot of people to maintain a healthy weight. So I think top-down approaches need to be introduced to help with that.
Cool. And another one, who are the reference group that BMI healthy ranged is based on? Is this an argument that BMI is not fit for purpose for monitoring health on non-white individuals?
So I don't know. I'm just trying to think who was the reference group. I mean, I'll answer the second part first. Then, if I don't know if I'll answer the question overall. I think there is an argument that BMI is useful. And we always hear that. How useful is it? And more, BMI is one factor that should be taken with lots of other factors to get a holistic picture of someone's health. And so, for example, waist circumference, for example, fat percentage, muscle mass, all these things in an ideal world need to be measured to get a real good viewpoint on an individual and their health status. So it's not the be all and end all. I think it, within reason, is fit for purpose because it's a very simple and cost effective measure. But to base, you should never take that as the gospel and just completely base everything on BMI. You should treat things as a whole and try and understand more about the individual clearly. But I think it is a useful measure, especially in things like GP practices, for example. And then I think the BMI of 25 was chosen in a white group, for example, because based on lots of work that had been done, disease risk, for example, type 2 diabetes prevalence and other, diseases, the risk from historically was found to increase at about a range from there, and similarly about 30. However, I think these potentially may be a bit outdated, and as you mentioned, they need to be updated and also take into consideration other factors.
Okay. Okay, this is quite a long one, so bear with me. I saw a paper in the Lancet which found overcrowding in houses predicted the risk of COVID morbidity and mortality independent of BMI. Could we be potentially focusing on a false correlation here? Maybe focusing on other factors is important rather than just BMI, where a lot of the evidence is correlational.
Yeah, no, I completely agree that other factors such as, well, specifically for COVID-19 risk, we've done a lot of work around deprivation, around housing conditions, around type of employment. All these social factors are hugely important in a person's life of any ethnicity. And these are all factors that have been found to be independently associated with COVID-19 risk, whether that's testing positive or whether that's, harder outcomes like being admitted to hospital and dying. However, there is a strong body of evidence so that BMI is an important factor, and that's for all ethnic groups. So I don't think it's important to focus on all of it, and this is just a snapshot of some of the work we've done or I've done. We also look at things around deprivation, around household size, which are all, I agree, hugely important, especially in this pandemic. I think what this has done is brought to the fore ethnic inequality or ethnic social inequality and how important that could be. But from the research previous and even now, BMI does seem to be an important factor. So there is definitely, warrant in this investigation. But, there is as well in more social factors. And these clearly are into play because the more deprived a person is, generally speaking, what we see is they have high levels of BMI as well.
Okay. Another one for you. When regarding white ethnicity as a whole, e.g. USA, Canada, Australia, and the rest of Europe, are the same trends seen compared to minority groups?
Mm-hmm. So it's very difficult. So, a lot of the data here I presented today is predominantly only in UK based white British people or white European people within the UK. But when we go to America, we see similar trends. So, for example, Black African or Hispanic individuals are at increased risk of COVID-19, whether that's related to BMI or whether that's related to more social factors like the previous question just spoke about. So we do see in other countries, unfortunately, other countries such as, for example, France is a diverse country, but they have such poor, or maybe not so poor, but they have quite poor collection of data around ethnicity. So it's actually very difficult to get accurate estimates on ethnic inequality and ethnic risk in these different countries. So that's one stumbling block that we have looking at other countries. And clearly not all countries are as diverse as the UK, but America's a good sort of reference point, and it's similar to there. However, clearly when we go to the South Asian subcontinent or Africa, for example, it's very difficult because there is, there aren't as many white British people there to compare to. But I would suspect the difference is probably driven more by things here like what we mentioned, social, deprivation, and the fact that ethnic minority groups sometimes are potentially marginalized. So that's why they show increased risk. Whereas if you go to India, for example, if you're looking at an Indian individual, their risk, relative to their population wouldn't be any worse.
Lovely. Thanks, Cameron. I'm looking at the time. There are more questions in the chat. So what I will probably do is save a transcript of the chat and send it across to you. And then maybe we can either put the questions online or contact people directly. There's also a lot of very positive feedback in the chat. So can I just thank you again for a really interesting talk, and also thanks to everyone that attended tonight. And hopefully we'll see you at one of these events again soon. Yep. So have a good evening, everybody.
Thank you very much. Have a good evening, everyone.